Good morning. It is the 9th of May 2021. This is Dr. Deepak Natarajan, Chief of Cardiology, the Supreme Hospital, Delhi NCR. We have landed in a dark hole, largely because of ourselves. The performance of the government has been rather shabby. In fact, 50 years down the line, this government will be considered as one of the most incompetent governments ever. Every arm of this government has failed in tackling this pandemic. That is for all of you to see. However, you have to take these reports, which are published in international newspapers as also ours, with some skepticism. I urge you to analyze the reports very carefully, regardless of the fact whether they are published in the New York Times, the Washington Post, the Guardian, or the Sunday Times, because the figures are sometimes being just bandied about. The fact is that about 4,000 people are dying in a day in this country. Around 4 lakh cases are being detected. If we presume, and this is a safe presumption, that for every case detected, there are 10 more cases walking around which are either asymptomatic or mildly symptomatic, then we probably are having around 40 lakh cases in a day, which means that we have an infection fatality rate of just 0.1%. Now, for the sake of an argument, we increase the deaths from 4,000 to 8,000. Let us double the number. We still have an IFR of 0.2%, which is quite expected as per the leading epidemiologists of the world. I have mentioned this earlier. Epidemiologists from Stanford have calculated, based on many seroprevalence studies, that the IFR of the world is around 0.15%. So we are right there between 0.1% and 0.2%. Now, having said that, I'm very concerned because we have these foreign doctors passing opinions. They are safely ensconced thousands of kilometers away with very little knowledge, if absolutely no knowledge, of what is happening here. Now we have this British doctor who has been talking about the increased surge and the increased fatality in this country, and he is theorizing that maybe it is because of vitamin D. But he is completely ignoring the fact that our people have been not following the rules, the basic, simple, commonsensical rules of prevention of this disease. He has absolutely no idea that on an average day in Delhi, in a three-wheeler, which is supposed to support 3 people, that three-wheeler was supporting almost 9 to 10 people, and most of these people were without any regard for precautions, without any masks, which means that this was a sure recipe for disaster. We are talking about the Kumbh Mela. That was, of course, a huge and a terrible mistake, a tragic mistake. But we also had melas going along every day in the city of Delhi. We had melas in Karol Bagh market, we had melas in Khan market, we had melas in Lajpat Nagar market. I hope you get the drift. You understand what I'm trying to say? That is, people were thronging, people were hugging one another, embracing one another, and completely oblivious of the fact that there was a virus hovering around. So therefore, when I said right in the beginning that we were asking for this, okay? But if a British mathematician says that 1 million people have died because of COVID already, now that is something bizarre, that is bordering on plain stupidity. Now, I know some people want to topple this government. If they had their way, they would want this government to go down tonight. In fact, this very afternoon. But that would be far-fetched, because even if you want that, you have to support your arguments with facts, not with the suppositions, not with, absolutely incredible statements, which do not provide you any credibility whatsoever. So when you start talking about 1 million, that means 10 lakh already dying because of COVID in this country, then you are doing yourself no service. In fact, these facts, these so-called facts will come back to haunt you, and they are not doing you any good, or your concerned parties, or your concerned agendas. So this is very important. You just cannot go around saying, living about 8,000 kilometers from here, whatever, in a small island, which is far, far away from this country, from the realities of this country. We cannot have an arithmetic professor saying that 10 lakh people have already died because of COVID. This is a bizarre and an irresponsible statement. This is not scaremongering. This is not fear-mongering. This is just, what should I say now? This is simply absurd. This is an absurdity. This is what should I call it? This is something really absurd. I don't even have the vocabulary to describe this sort of absurdity. All right? This is rumor mongering, yes, at its best, and at worst, this is extremely irresponsible, because you all know that this is an extremely serious situation we are facing. And I am very concerned because my colleagues have died. There is a senior gastroenterologist who headed a department in a big hospital, corporate hospital of the city, who died because there was no oxygen. So therefore, as far as I'm concerned, this is a very, very serious matter. I am going to my hospital every day for the last 1.5 years. I am confronted by patients, many of them who have COVID presently. And therefore, I have been at considerable risk. It's a different matter that I have been vaccinated. I have had both my shots. But we all know that the efficacy of the average vaccine, whichever one it is, I'm not talking about the messenger RNA vaccines, the average efficacy would be around 60%. So that's it. Your protection is only 60%. So then we have this American doctor who wears a lovely bow tie all the time. And this man has a lot of hair also on his head, who has been in a video which was up yesterday or day before, wherein he is also expressing concern about the crisis in India, and he is a bit astonished that we are not using monoclonal antibodies. Now this is a pretty strange way of looking at things, because we know, and he should know, that monoclonal antibodies cost a lot of money. They are not here, and most importantly, the monoclonal antibody made by Lilly does not work against the variants which are present in India. Now we have two variants operating in India. One is the B117, and the second one is the Indian variant, which is also called B1617. But so far, we know, based upon data, that these variants may be slightly more infective. They are not, and I repeat, there is no data which supports the assumption that the Indian variant is more deadly. You see, the numbers are increasing. That is an absolute figure. And the numbers may be increasing because of an overreaction by the doctors who are treating this disease. Doctors are overburdened, overwhelmed by this virus. They are nervous. They may be slightly confused also, but they are doing their best. That goes without saying. But maybe one factor is that the patient concerned is seeking medical attention too late, or that the prescriptions provided to these people, to the patients, are slightly over the top, or they are exaggerated. However, my talk today would largely be on what is being talked about now, that is the effect of this virus on the human heart. Now, I can say with some authority that the effect on the heart is minimal. There was a paper last year in July which was published by the Germans, and which I have spoken already about. This paper was an MRI done about 2 months after a COVID infection in 100 people. Half of them were men, and the average age was around 49 years. And what this study showed was that almost 75% of these patients, as late as 2 months after the original, after the index infection had some sort of an inflammation as seen by the MRI. This was a raised T1 and a raised T2 value. Now, this was an MRI paper, and this is not necessarily the truth. The MRI is showing some kind of edema in the heart, but this was not a specific finding, albeit this study was much talked about in the medical world. But now we know, because now we know by pathologists that the incidence or the prevalence of inflammation in the heart is very, very low. We have an excellent paper. It is a review article, a state-of-the-art article by a bunch of the world's leading heart pathologists. These people have reviewed almost 200 autopsied hearts. So now we are talking about people who were most seriously ill. They were so sick that they died because of COVID. These 200 hearts, only around 9 of them had the presence of the COVID virus. That is a prevalence of just 4.5%. And even these hearts did not have any necrosis or damage of the cardiac cells. Now, this is very important. The definition of myocarditis because of COVID or any virus is a combination of the destruction of the heart cell under the microscope, accompanied by the presence of inflammatory cells, particularly what are called T cells and macrophages. They have numbers for them, which I will not go into, but of course one number is 13. That means if there are more than 13 white cells per millimeter square in the presence of a destroyed cardiac cell, then that is myocarditis. Now we come back to this paper, this review article published in JACC, that is the Journal of American College of Cardiology, which is one of the most important journals in the world in cardiology. Now, this review article clearly says that of these 200 autopsied hearts, despite the fact that there were these the virus in about 9 hearts, there was no evidence of necrosis or damage or cell death in these hearts, which means, strictly speaking, there was no myocarditis as described conventionally by the top pathologists of the world. Apart from this, they also produced data on 16 of their own autopsies, 16 autopsied hearts which they collected from Italy. And here again, they had just 2 hearts which had the presence of the virus, but there was no evidence of inflammatory cells. So they conclude that although there is something seen by the cardiac MRI which suggests that there is edema, in actuality, and of course we all know that the final diagnosis depends upon the histopath of the cardiac cell, based on their definition, which is, I repeat again, the presence of a dead cell and the presence of inflammatory cells such as macrophages and T cells, not a single of these 16 autopsied hearts showed myocarditis. So the take-home message is that even though there would be some murmurs now, a lot of people will start talking about heart involvement after COVID-19, in reality, the incidence or the prevalence is very, very low. It is just less than 1% or 2%. And even here, we are talking about people who have died because of COVID. In the regular patient who is at home or who is minimally symptomatic, the chances of the heart being affected are extremely remote. Now, if I see a patient who comes in after COVID-19, after a fortnight of COVID-19, and he or she is throwing some ventricular ectopics, that is misbeats, I have no way of confirming whether COVID-19 has caused this arrhythmia or whether the ectopics were preceding the COVID-19. So the best thing which I can do is to do an echo, and if the heart function is normal, if the valves are normal, if the pericardium, which is the case in which the heart is enclosed, is normal, then I would leave such a person alone. Because even if a person very, very though rarely has myocarditis, we don't know how to treat. We have to treat them as usual. So therefore, we have to wait for the heart to get damaged to such an extent that there actually is heart failure, and then we begin the usual treatment for heart failure. So this is the first aspect of heart disease. Let me reassure you, and I'm not trying to reassure you, I'm giving you scientific facts that based upon data, based upon scientific data, the effect on the heart by this virus is minimal, right? So please do not get upset. Please do not get nervous or scared if someone says that the heart is being affected by this virus and people are actually dying because of heart disease because of the virus. It is a different thing altogether that a person who already has risk factors, for instance, a middle-aged person, a middle-aged man who was or is a smoker, who has diabetes, who has hypertension, and who has been, it is hoped, not exercising for the last 4 or 5 months, then obviously the man has put on some weight, his sugar might have got deranged, so therefore that may contribute to the regular atherosclerosis, that is a blockage of the heart. But so far we have absolutely no data that this virus is contributing to atherosclerosis directly, or whether this virus is contributing directly to the cardiac cell destruction. The second big aspect, which is also very, very important, is the fact on repolarization of the heart. Now, this is a concept. What has been seen by electrophysiologists and what is known for the last more than 50, 60, 70 years is that the cardiac cell or any cell, especially the heart cell, is at a level which is minus. This is the state of, the basal state. And then the sodium channel opens up. When the sodium channel opens up, sodium comes in to the cell. When the sodium comes into the cell, the cardiac cell becomes less negative and actually goes positive, right? So here the sodium is entering into the cardiac cell at great speed. Then the sodium ions stop getting into the cell, and now the potassium channels open and the potassium starts getting out of the cell. So then there is what is called repolarization, and the wave, the electrical curve starts going back to negative. So we have a negative basal line to begin with. The cardiac cell depolarizes, it goes up, it becomes positive because of the entry of sodium ions. Once the sodium ions have filled the cardiac cell, then the potassium ions within the cell starts to get out via the potassium channels, and we have what is called repolarization, and the voltage in the cell drops down to the basal level, which is actually below the basal level at a negative point. So this is depolarization and repolarization. Now there are certain situations wherein the process of repolarization gets lengthened, it gets expanded. Now this is not good for the heart, because when repolarization gets expanded or lengthened or elongated, then the heart is vulnerable to dangerous arrhythmias such as ventricular tachycardia, polymorphic ventricular tachycardia, and even ventricular fibrillation, which means a sudden cardiac death. So you may have heard of a certain person suddenly dying. This may have been the cause. Now the causes of the reflection of the prolonged repolarization on the ECG is what is called a lengthened or an elongated or a prolonged QT interval. Q is the beginning of the QRS complex on the ECG, and the point T is at the end of the T wave. I won't try to explain that to you because that will confuse you. That is best known to doctors. But the fact is that there is a certain measurement on the ECG which is called the QT interval. If the QT interval is prolonged, especially if this QT prolongation is more than 500 milliseconds, then that is a dangerous situation to be in. Now, what causes elongation or the prolongation of QT interval? Now, one is a congenital defect. Some people are born with this defect. Of course, they are very few. I will not go into that. But the more common variety is because of electrolyte imbalance or medicines. When the potassium in the body is below normal, or when magnesium is below normal, that's when the QT gets prolonged. And also a number of medicines are notorious for causing QT prolongation. One of them is dihydroxychloroquine. The other one is azithromycin or erythromycin. And of course, both the drugs carry the black box warning by the FDA that they can prolong the QT. Now, we come to COVID-19. There has been an excellent paper which was published a few weeks back in the JAMA. This was an American paper of 1,000 people admitted in a hospital because of query COVID-19. Of these, 75% were found to be having confirmed COVID-19 by the PCR test. 25% did not have COVID-19. About 58% were men, and 20% were above the age of 80 years. What did the researchers find? The researchers found that in the people, in the cohort or the group which had COVID-19, there was an increase in the QT interval by almost 20 to 25 milliseconds. Also, scaringly, people who had COVID-19 already had a QT interval of more than 500 milliseconds. But reassuringly, only one person in this entire cohort developed a torsade de Pontis, that is a polymorphic ventricular tachycardia. This was a woman. Now, women do have a prolonged QT as it is. This was a lady with a prolonged QT interval. She had a weak heart because of a previous cardiomyopathy. Her magnesium level was low, and she was on azithromycin. So what I am suggesting to you, and especially to any doctor who is watching this video, is that if a person has COVID-19, we know that this virus can interfere with the potassium channel. By interfering or dampening the potassium channel, it delays or obstructs the efflux or the removal of potassium from the cardiac cell. By doing that, it prolongs the repolarization time, and on the ECG, this is manifested as a lengthened QT interval, and such people, excuse me, are vulnerable to sudden death because of ventricular tachycardia. So if you have a patient who is a lady who already has a weak heart because of a previous heart attack or because of a previous viral infection and who develops COVID-19, one has to be very, very sure as to what is the potassium level, and one has to be very careful as to what drugs we are giving, because a combination of all these factors can make this person very vulnerable. Now, thank you very much for watching this video. I will finish this video once again by telling you that the most important component of our arsenal against this current pandemic is not a vaccine, it is not medicines, but it is NPI, it is non-pharmaceutical intervention. This must be hammered into every individual you know, whether he is rich or whether he is poor, whether he is young or whether she is old. It is imperative that we blast them, that we hammer them with the fact that they must, from now on, for maybe the next 2 years, they must maintain some distance from other people. They must wear a mask in a crowded place. I keep seeing people in my own hospital, people, of course, who are not doctors, but who are patients or paramedical staff who are bunched together. Now, that is a very, very dangerous situation. We have to tell the public, yes, vaccines are very, very important. Every one of you who can should get a vaccine. Drugs are very important, but non-pharmaceutical intervention, that is NPI, is most important because that is free of cost and which would be most effective in preventing an infection. Until we get into some sort of an equilibrium, I would strongly suggest that people adopt prophylaxis with ivermectin, because there is enough data now, enough controlled data, that ivermectin tablets taken once a week can reduce infections by this virus substantially, in fact to the tune of 88 to 90%. Having said this, I will stop now. So once again, thank you very much for watching this video.